Let me explain about the case study about the MI. Number 1, patient profile. Name Mr. Ramesh Kumar, age 58 years, gender male. Second, chief complaints. The patient presented with a severe central chest pain for 2 hours and pain radiating to left arm and the jaw, sweating and shortness of breath, and usually a nausea and dizziness, fatigue, vomiting, like some kind of chief complaints. Past medical history. History of hypertension for about 10 years and type 2 diabetes mellitus for about 6 years. And there is a presentation of dyslipidemia, high cholesterol levels, no previous history of myocardial infarction, no non-H drug allergies, irregular medication compliances. Okay, let's get into the present medical illness. The patient was apparently normal until 2 hours before the admission, when he developed sudden severe crushing retrosternal chest pain while climbing the stairs. Let's get into the characteristics of pain that a patient underwent. Intensity 9 to 10, nature heavy and squeezing type, duration continuous for more than 30 minutes, radiation from left shoulder to left arm and jaw. Associated symptoms sweating, palpitations and breathlessness, nausea. The patient was brought to the emergency department immediately. Vitals, parameters, temperature, pulse rate, blood pressure and respiratory rate, SpO2, random blood sugar. Okay, let's get into the temperature. 98.6 degree, pulse rate 100 beats per minute, blood pressure 150 by 90 mmHg, respiratory rate about 24 beats, SpO2 about 93% on room air, random blood sugar 248 mg by liter. Okay, let's get into the personal history of the patient. Smoker for 25 years and occasional alcohol consumption, sedentary lifestyle, mixed diet with high fat intake, disturbed sleep due to the work stress, and detailed diagnosis of the patient was clinical diagnosis, acute ST elevation, myocardial infarction, ST anterior wall MI. Okay, let's get into the ECG findings. ST segment elevation in leads V1 to V4, pathological Q waves in anterior leads, sinus tachycardia, T-wave inversion developing later. Interpretation. The ECG findings indicate acute anterior wall MI due to the occlusion of the left anterior descending coronary artery. Get into the echo findings. Hypokinesia of anterior wall, reduced left ventricular ejection fraction LVEF about 40%, mild left ventricular dysfunction, no significant valvular abnormality and mild mitral regurgitation present. Interpretation. Echo confirms the impaired myocardial contractility due to the ischemic damage. Let's get into the laboratory investigations. Troponin I positive, CK-MB elevated, total cholesterol level was increased and LDL level also increased. Okay, then let's get into the management. Emergency management. Patient kept on the cardiac monitoring, oxygen administered at 4 liters per minute, intravenous access secure and continuous ECG monitoring was done. Let's get into the medical management. MOLA therapy.
Attack is chest pain, but symptoms can vary from person to person. A heart attack can also feel like pressure, heaviness, tightness, or squeezing across your chest. Other symptoms include pain that feels like it's spreading from your chest to your arms, usually the left arm, your jaw, neck, back and tummy. Feeling lightheaded or dizzy, shortness of breath, sweating, feeling or being sick, coughing or wheezing, and a sense of unease or anxiety. Some people may only experience minor chest pain or something that feels like indigestion. Some may have no chest pain at all. It's important to know that the signs of a heart attack do not always feel or look severe like they do on TV and in films. But
which means morphine, oxygen, nitroglycerin and aspirin. Morphine for severe pain relief and oxygen to improve their oxygenation. Nitroglycerin for chest pain and vasodilation. Aspirin to antiplatelets therapy. Okay, let's get into the reperfusion therapy. Primary percutaneous coronary intervention. which means PCI, coronary angioplasty, which showed the LA artery blockage, angioplasty with stent placement performed successfully, and nursing management, monitor vital signs regularly, assess the chest pain characteristics, monitor ECG changes, maintain the bed rest during the acute phase, administrated medications as prescribed, provide psychological support. Okay, finally, let's conclude the case study. The patient was diagnosed with acute anterior wall STEMI based on the clinical symptoms, ECG changes, elevated cardiac biomarkers and echo findings, early diagnosis and timely PCI significantly improved prognosis and reduced complications. The patient was advised strictly lifestyle modification, smoking cessation, diabetic control and regular follow-up to prevent their recurrence.